So I'll be taking you through approach to post-operative fever. So coming to the definition, so if the core temperature is more than 38 degrees on 2 consecutive days, or 39 more than 39 degrees on one day or one occasion, then it is called as post-operative fever. Usually it is defined by the core temperature, which is ideally the rectal temperature or the nasal temperature, which we use in ICUs, which are nasal probes. Otherwise, commonly we take axillary or the oral temperature. So that can be considered 0.5 degrees less than the core temperature. Now, how does it occur? The fever pathophysiology, as we all know, it is a manifestation of cytokine release and response to all the inflammatory factors. And the inflammatory factors which are commonly enumerated to cause fever are IL-1, IL-6, the TNF alpha, and interferon gamma. I'm not going to the details of all these. They actually act on the hypothalamic endothelium and raise the set point of hypothalamic thermostat. And this allows the body to produce heat and conserve heat, which manifests as fever. So we are more concerned about what are the causes of this cytokine release, whether it is infectious or non-infectious. So just to remember, there are there is a synonym for post-operative fever, that is 6 Ws. So the Ws include wind, water, wound, walk, wonder drug, and the wonky glands. So I'll be taking you through all these 6 Ws in short. And the first one is wind, that is atelectasis, which usually occurs within 24 to 48 hours of a surgery, which was done under general anesthesia. It might occur under regional anesthesia as well, but it is more common in surgeries which occur under general anesthesia. The pathophysiology remains that the patient remains in recumbent position. So the timing of surgery is important. So if the surgery is prolonged, then the chances of atelectasis is high. And the post-operative sedation as well as pain, which doesn't allow the patient to move his thorax comfortably or use his breathing capacity to the maximum, that causes atelectasis. The clinical features include tachypnea, cough, dyspnea. There may be crackles on auscultation. The patient may have some amount of hypoxemia, and there may be basal infiltrates on the chest X-ray if done. The management includes early mobilization, incentive spirometry, adequate pain relief, and bronchodilators. Now, there are other causes of fever because of uh, causes which affect the lungs, and one of the most common is pneumonia. The pneumonia can be community acquired, so the patient might have had contacted the bacteria prior to admission or prior to surgery, which was not detected in the preoperative period and may manifest later, say within 48 to 72 hours of surgery. If it is manifesting, then it can be termed as community acquired chest infection, or it may be VAP if the patient was on prolonged ventilation for more than 48 hours post surgery. It can be ventilator associated pneumonia also. Or if the patient was in altered sensorium, or there was pressure ventilation was used in the post operative period, or there was history of vomiting in an state of, say, partial consciousness, or the patient was not in full GCS, then there can be aspiration pneumonitis also. And if the patient had DVT or manifests with hypoxia and tachycardia, it can be pulmonary embolism as well. So these are the various causes of fever in the post-operative period, the most common being atelectasis. So these are the chest X-ray. You can see there is basal atelectasis in more on the left side in this chest X-ray. In the second X-ray, you can always see there is a consolidation patch, which is more suggestive of pneumonia. In third X-ray, you can see diffuse infiltrates all over the body, all over the chest in bilateral lung fields. And this happened when the patient aspirated after a bout of vomiting. This was in a patient recently who developed aspiration pneumonitis in our ICU on postoperative day 5. Then the second W is water, that is urinary tract infection, which usually manifests within 48 to 72 hours. The risk factors include old age, females, if there is length of catheterization is important, or even if the patient was catheterized and the catheter was removed on POD1 or say on the same day, Then also it forms a risk for UTI in the postoperative period. The other risk factors include uncontrolled diabetes and history of previous UTIs. So the symptoms include fever, increased frequency, urgency, or suprapubic pain. Or the patient may complain of the burning micturition if the catheter has been removed. If it has not been removed, there may be pain in the periurethral area. The majority of the patients remain asymptomatic. Once the catheter is removed, the symptoms subside. But if the culture turns out to be positive and there is symptomatic pyuria, it needs antibiotic cover based on the culture sensitivity or the local uh, culture sensitivity pattern. The most common organisms include E. coli and Enterococcus. At times, it may be Candida species as well. Empirical treatment is directed by local resistance pattern and the patient's condition and comorbidities till the culture sensitivity arrives. So, as I said, majority get relieved on their own, but if the patient is symptomatic or is in sepsis, then it needs treatment and attention. The third W is wound, that is superficial or deep surgical site infection. Infections that occur at or near surgical site within 30 days of surgery or within 90 days if there has been implants, especially in orthopedic surgery, it is termed as surgical site infection. It usually manifests on POD 5 to 10. However, it may manifest in the early period, like within 1 to 3 days, in infection with Clostridia or group A streptococci. So these patients are usually infected prior to the surgery and they manifest in the post-operative period when the patient is immunosuppressed. Now, the types of wound infection can be superficial, as I said. It involves the skin and the subcutaneous tissue. As you can see in the first photograph, it is a small photograph, but you can appreciate that there is some incisional erythema and there may be some serous discharge. However, there is no tenderness and no major purulent discharge from the wound. The second photograph shows a deep SSI in which the fascia and the muscle are involved. And the third photograph shows the organ space SSI, where you can see blisters over the skin suggestive of necrotizing fasciitis. And probably it is a deep-seated infection in the organ space, maybe because of an anastomotic leak or abscess in the abdominal cavity. The risk factors for SSI include, again, old age, poor nutrition, and obesity, which are obvious, uncontrolled diabetes, smoking, which affects the wound healing, and impaired immune status in the form of, say, the patient is HIV positive or on immunosuppressants or on corticosteroids, and there are other concomitant infection. In these cases, the SSI rate is high. Now, what should we do when we encounter a superficial surgical site infection? So, routine culture swabs should be avoided because it is usually contaminated with the skin flora. However, if there is a purulent drainage and the patient is running fever, continuous or recurrent, then it needs to be evaluated. In that case, we do send for culture sensitivity. Otherwise, it is not routinely sent. The patients with sepsis should be suspected to be a case of deep SSI or organ space SSI, and they need imaging as well in the form of ultrasound or CECT to evaluate the internal organs. The most common pathogens causing SSI include varies with the site of surgery and hospital stay. So if it is a say a thyroid surgery or a breast surgery or a peripheral limb surgery, then the chances of gram-positive bacteria affecting the wound is more, that is Streptococcus or Staphylococcus. But if it is a chest surgery or an abdominal surgery, then the chances of gram-negative bacteria and enterococci is higher. So in patients who are septic or who are symptomatic, they do need antibiotics according to should be started according to the site of surgery, followed by the culture sensitivity report, which should guide us for the further management. Coming to the fourth W, that is walking, that is DVT and pulmonary embolism. So any surgery is a prothrombotic state, and post-op DVT it accounts for 20% of all hospital-acquired DVTs, and it usually occurs in the later half of the surgical period, that is usually beyond POD 4 and 5, and it may occur up till if the patient remains hospitalized, the risk of DVT remains till the patient is discharged. The high risk cases are abdominal and pelvic surgery, lower extremity orthopedic surgery because patients remain immobilized for a longer time, Major trauma or spinal cord injury, again because the patient remains immobilized for a long time, and malignancy and obesity, which are prothrombotic states. Patients can present with PE without signs of DVT. So the patients may not have a leg swelling, may not have a tenderness in the calf, but still may have pulmonary embolism. And this is because there may be thrombus in the proximal veins and may not manifest as a overt deep vein thrombosis. So if a DVT is suspected, then color Doppler should be done immediately, and therapeutic anticoagulation should be started if there is no contraindication to it. Now coming to the wonder about drugs. So there are multiple drugs which can cause fever, and it is the most common non-infectious cause of fever in the post-operative patient and can occur on any post-operative day. That is most important. So one of the most important thing which can cause fever in the post-operative period is the transfusion of blood products. The other medications which can cause fever, you name any medication and that can cause fevers, be it heparin, be it antimicrobials, say vancomycin or beta-lactam, which include every and common antibiotic which we use, anticonvulsants like phenytoin. So how do they cause fever? It can be because of the infusion site inflammation, especially when we give potassium or PPI through the uh, peripheral veins. Then it is more commonly it causes the venous thrombophlebitis. Then there are drugs which can stimulate heat production like thyroxine. There are drugs which limit the heat dissipation, that is atropine and epinephrine. And there are drugs which can alter the thermoregulation like antihistaminics and Parkinson drugs. So I told you there any drug you name it and it can cause fever in the post-operative period. So another W which is uncommonly discussed, that is the wonky gland. Wonky means which is not straight. So there are two glands in our body which are not straight. They have erratic functions. So adrenal insufficiency and thyrotoxicosis. So these are the two uh, situations in which the patient may develop fever along with other manifestations. So adrenal insufficiency can present with fever with hypotension, hyponatremia, hyperkalemia, and hypoglycemia. And it is usually in patients who undergo adrenal surgery or already have a adrenal suppression. So management includes maintenance of euglycemia, hydrocortisone infusion, and fluid resuscitation, obviously. Thyrotoxicosis can occur in all patients who are suffering from some thyroiditis or have evidence of hyperthyroidism. It can present with tachycardia, hypertension, hypothermia. The management includes again propranolol, propylthiouracil, and iodine. So it doesn't occur in every patient, but yes, in endocrine ward, you should be very cautious about these two factors. So how to approach a case of post-operative fever? So first of all, evaluate the patient, that is ABC, which is very important because the fever can be killing also. So once you go to the patient, you always examine for the airway, breathing, and circulation. You may not be the person who has seen the patient during the surgery. You may be the first person in ICU to attend the person who doesn't know about the history prior. So first of all, you should go and assess the airway, breathing, and circulation. Once you are happy with the airway, breathing, and circulation, you go for the evaluation of the cause of fever. So first step is history. It is always there. So history is the most important. You should know about the preoperative status of the patient that can be taken care of by the notes which are present with the patient, or you may even ask uh, the treating doctor. So pre-op status should be known, the comorbidity should be assessed, whether there was controlled, uncontrolled diabetes, any thyroid ailment, any adrenal ailment. So these things should be assessed. Then the extent and nature of the surgery is very important. The nature of anesthesia is very important, and grade and frequency of the fever, that is also to be assessed. Now, second comes the evaluation of nursing chart in detail. So course of stay in the hospital, say the patient presented with fever on fifth day. So you should always see the nursing chart, whether the patient had a drain in place or not, when it was taken out, whether the patient had tachycardia or tachypnea any time prior to that episode of fever. So everything should be taken care of, whether there was blood transfusion or any medications which the nurses have given or administered to the patient. Then comes the symptoms. So along the fever, if there is rash, cough, dyspnea, chest pain, so rash may be present, may be a sign of allergy, maybe due to medications, due to transfusion. Cough and dyspnea and chest pain are more suggestive of there is some chest ailment, maybe atelectasis, maybe pneumonia, maybe a pulmonary embolism. Then dysuria, maybe because of UTI, the patient is running fever, leg swelling to rule out DVT, IV site thrombophlebitis, abdominal pain or discharge from the wound should always be assessed if you are suspecting SSI. So these things should be looked for. Then comes the signs which you should look for. Again, we have to confirm the symptoms by evaluating the surgical site in detail, doing the chest examination in detail, and abdominal examination to rule out cholecystitis or any abdominal collection or something like with fever, something like deep SSI. And apart from that, you have to evaluate the IV sites also, and you have to evaluate the Foley's tube also. So all these constitute the assessment of the patient who presents with fever in the post-operative period. How do you evaluate? So evaluation should always be guided by your assessment, initial assessment. So you send for a hemogram, you send for cultures depending upon what is the matter of concern. So if you know that the patient is on Foley's for a long period and is running fever, then it is more important to send a urine culture rather than sputum, tracheal aspirate or pus. You know, and if the patient has purulent discharge from the wound, then it is more important that you send for the pus culture rather than the urine and sputum, concentrating on the urine and sputum. And but blood culture is very important. Blood culture should be sent, I think, in all cases of fever if the patient is septic. Stat gram staining is important if you're suspecting necrotizing fasciitis because it is a infection which needs to be treated as soon as possible. Then comes the imaging. So imaging can be chest x-rays, which can be important in patients with pneumonia or regular follow-up in patients with post-operative fever. Contrast enhanced CT scan, that is important to evaluate for anastomotic leaks and to evaluate for abscesses in the intra-abdominal or intrathoracic cavity. And pulmonary embolism, if we suspect a pulmonary embolism, then CT angio of the chest is important to look for the thrombus in pulmonary vessels. Then color Doppler, if we are suspecting a DVT, ultrasound, if we are suspecting a cholecystitis or an intra-abdominal collection. Then C. diff toxin assay can be sent in few patients if they are presenting with diarrhea with fever and we do not find any other cause, substantial cause of fever in those patients. So all the evaluation should be guided by the initial examination and initial symptomology. So as I already stated, the most common causes of fever in POD 1 and 2 will be atelectasis, and apart from that, there can be persistent infection in a patient operated in emergency or other causes which are not that common, but it should be thought of. One of them is transfusion reaction, then thyroid crisis, malignant hyperthermia, these are rare causes, and any drug causing fever in perioperative period. If the fever occurs in perioperative period, these things should always be thought of. On POD 3 and 5, it is the infection which sets in, and it is usually related to the indwelling devices, say cystitis or UTI because of the catheter. Sinusitis may occur because of the indwelling Ryle's tube in the patient's nasal cavity. So it may imbibe bacteria and cause sinusitis. Thrombophlebitis may occur if there is a peripheral vein in use for more than 48 hours or there is some spillage in the local area. Then hematoma in the wound or hematoma in the abdominal cavity or thoracic cavity that can develop infection and cause fever from POD 3 to 5. Tissue necrosis and chest infection that may be present in within 3 to 5 days of any surgery. Now from POD 5 to 8, that is around a week of surgery, the most important cause of fever in GI patients is anastomotic leak. Apart from that, wound infection or intra-abdominal abscess or intrathoracic abscess, these can cause fever from POD 5 to 8. The rare causes can be antibiotic-induced diarrhea, and DVT and pulmonary embolism can occur in any patient with a major surgery from POD4 and onwards. So what is important is, uh, can we prevent the fever in the post-operative period? Yes, prevention is possible, and it is always better than the cure. So the preventive measures which we should take is early ambulation, use of anticoagulants in case of major surgery wherever it is indicated, active chest physiotherapy to begin, and it should begin pre-operatively, so the patient is tuned to do it in the post-operative period when he or she has pain. Then also he knows how to do chest physiotherapy and he will do it. There should be adequate pain control. We should use epidural blocks. We should use regional blocks to avoid pain in the post-operative period, to comfort the patient and allow them to do chest exercises as much as possible. We should avoid catheters as much as possible. We should practice early removal of drains, and we should go for early oral intake so that there is less translocation of bacteria through the gut, and we should avoid unnecessary transfusions. So these all can prevent fever in the post-operative period. So what is the take-home message? That early fever is usually non-infectious. Majority resolves spontaneously. The early causes of fever within 1 to 3 days. Exceptions include fever following emergency surgery or soft tissue infection, which may require intervention. The fever occurring on or after 5 days is usually infectious and should be taken care of. Deadly causes of postoperative fever include necrotizing infection, Clostridium infection, transfusion reactions, which can prove fatal in no time. So we should be very careful about that. Pulmonary embolism can cause a mild fever and more of pulmonary symptoms. An anastomotic leak, if not taken care of, can cause sepsis and death. So these things uh, should be known to the person who is taking care of the post-op in the post-operative period, and should take adequate measures in time. Rare causes of fever include sinusitis, meningitis, perirectal abscess, acute cholecystitis, parotitis. While these should always be kept in mind. While if the patient is for weeks in the hospital, then endocarditis and prostatic infection can also cause fever. If I have time, I can go for few case scenarios. So somebody will would have to help me out with case scenarios because I'll be asking questions. So I cannot hear the to the people sitting behind. So if
There's a mic here, so I think people can answer. Yeah.
okay, that's fine. A 58 year say case scenario one, a 58-year woman underwent mastectomy under general anesthesia. In the evening, she developed fever. That was 38.7 degrees Celsius. She complains of stitch line pain controlled on medications. There is mild serous discharge from the wound. She is not on any antibiotics. She only received a preoperative prophylactic antibiotic and hemodynamically stable. No catheter or central line is there. WBC count, which was sent in the postoperative period, was 9,500 per microliter. So what do you do next? So these are the options. So do you send for a urine culture? Do you do a blood culture? Do you do a bone swab and chest X-ray? Or you go for observation only?
So people are saying observation only.
So that's fine because this is a post-operative day 0 or day 1. There is one episode of fever that doesn't stand for a post-operative fever as well. It is just one episode of 38.7 degrees Celsius, and the patient is well controlled on pain. She is doing well. She is hemodynamically stable. No signs of sepsis, and no signs of SIRS, and so might be atelectasis, might be drug induced. So we should observe. If the patient repeats on fever, then we should go ahead. So that's fine. So second case is a 65-year obese diabetic male underwent open cholecystectomy for gangrenous cholecystitis. In the evening of surgery, the temperature was 40 degrees Celsius. Tachycardia was there, abdominal pain was there, and the saturation was 94% of room air. Altered mental status was there. There was local tenderness, skin blisters were present, and crepitus was present. There was dirty fluid coming out of the drain, and microscopy shows gram-positive rods. So what do you think is the diagnosis in this patient?
First answer is B, sir. Second answer is D. And final answer is step A, sir.
So you didn't listen to the question correctly. I told you it is altered mental status, local tenderness, skin blisters, crepitus present, and there was dirty fluid coming from the drain.
Necrotizing
And
fasciitis and Clostridium perfringens, sir.
yeah, correct. So it is likely a necrotizing fasciitis. The patient has been operated for gangrenous cholecystitis, you see, and there was gram negative, if I'm correct, there was gram positive rods which is seen on microscopy. So if it is gram positive rods, it has to be Clostridium perfringens. So what is the appropriate management?
C, sir.
Yes, it is C, because if it is necrotizing fasciitis, you have to do a surgical debridement immediately, along with addition of broad spectrum antibiotics, including broad spectrum penicillin and anaerobic cover, obviously. So the necrotizing fasciitis is of two types. Type 1, that is polymicrobial with aerobes and anaerobes, usually occurs after surgery in patients who have uncontrolled diabetes, obese, or pre-operative predisposition in the form of gangrenous cholecystitis. And type 2, that is monomicrobial, which is usually caused by group A streptococci and streptococcus pyogenes. So though MRSA is becoming more common for type 2, but this particular patient was probably a type 1 necrotizing fasciitis. So in all these patients, you have to go for ABC, intubate the patient, IV access, resuscitation, early broad spectrum penicillin G, and anaerobic cover should be given. And surgical debridement is a must, because antibiotics alone, mortality is 100% in necrotizing fasciitis. The case scenario 3, this is the last case scenario. 61 years female, undergoes a total hip replacement, has Foley's in situ, develops fever on POD1, resolves spontaneously. Foley's removed on POD1. She has been ambulating, doing spirometry, vitals are stable, and wound is healthy. The saturation is 99% on room air. She develops fever on POD4. So what is the likely cause of fever on POD4? Is it deep vein thrombosis, UTI, prosthesis infection, or superficial surgical site infection?
UTI.
Yeah, likely UTI, because I told you, as if the patient has a history of catheterization, then it causes for fever if it develops without any other symptoms of wound infection or difficulty in breathing, then likely the cause is UTI. So it cannot be SSI, cannot be deep vein it is not deep vein thrombosis, because she doesn't have any signs of DVT, and it is likely UTI, which is likely to resolve on its own, or we can start with a local antibiotic based on the local culture, and then follow up with the culture sensitivity report. So what is the take home message after all these case scenarios? We should be well versed with all the common causes of fever and the timings, that is the 6 Ws we talked about. We should always try to figure out the possible triggers which causes fever, and we should know what can prove fatal. Example, the pulmonary embolism, the necrotizing fasciitis, and transfusion reactions. And we should always have a working diagnosis before we embark on the investigations. So that's all from my side.